We're extremely lucky to have Ed Weisbart here tonight. He's PNHP National Board Member and Chair of the Missouri Chapter of PNHP. He received his medical degree at the University of Illinois in '79. Was that 13 years after me? and completed his family medicine residency and fellowship in family medicine at Michigan State University in '82. After practicing family medicine for 20 years at Rush Medical Center in Chicago, he moved to St. Louis to serve as Chief Medical Officer of Express Scripts till retiring in 2010. And since then, he's volunteered as an assistant professor of clinical medicine at Washington University in St. Louis, from which he fully retired clinically in 2021. So Ed speaks very frequently about the fragmentation and corruption of our medical bond system and how a national single-payer system would vastly improve it. And he has lots of videos and slideshows on the internet. Many of them are connected with the PNHP national website, but if you Google his name, you'll come across lots of information. Recently, with the current assault to privatize Medicare by the ACO-REACH strategy, Ed has had lots of requests to take a lead in the fight against this corrupt attempt to fully take over Medicare. And we are very lucky to have him here tonight to help us beef up our efforts in Washington State. And I should say that many of the people on this call tonight are members of different organizations that have been cooperating in a really amazing manner around this struggle in our state. So, Ed.
So I'm really a little bit overwhelmed when David asked me to talk about this, because we had not at that point actually built a sort of a tier 2 or level 2 discussion. But I'm so happy that you did invite me, because after you reached out to me, we've been getting requests elsewhere for really the same kind of discussion. So I'm not going to focus as much on Representative Kilmer as I am going to use him as a storyline at times in here, because I think the concerns that you raised and that he raised are national. They're not really unique to him. So I'm so glad that you sent me the information you did. I'm assuming in this discussion that all y'all have understanding of what the DCE and REACH program is, and I didn't plan any time to unpack what they actually are. If you need that, if you want me to go back into that, I'd be more than glad to. But instead, what I wanted to do was start by creating what I think of as almost an untold but really important contextual story arc that we didn't get to this point with the DCE REACH program overnight. But instead, it really started quite a while ago, and I believe there's a straight line from the HMO Act to today, and that's, I think, an important context, because you can learn a lot from the steps along the way. So we're going to take a little bit of time walking through what I think of as a really critical story arc that got us to today, and then we'll talk a bit about what's still incredibly, I think, flawed with where we are today. And specific content-rich, I hope, rebuttals to some of the charges that we're hearing from a variety of Congress folks. So I think it's really an important discussion. We need to be, we need to ramp up our game, and I'm hoping that this is a step in that direction. So that's kind of the run of show. Let me maybe start with a bit of news that you may have missed. So I think it's an important piece of news. This was called a milestone in better ways to improve well-being. Anybody see this article when it came out? So I'll just take some quotes. Financial incentive to keep its subscribers healthy. Shift the emphasis of the American medical care to the prevention of illness. Test under widely various circumstances in all parts of the country, and adequately tested in rural and central city settings where many potential subscribers would be medically underprivileged. Man, it sounds good. So would anybody recognize this, where this is from? It's from it was in the New York Times. in 1973 describing the HMO Act, which obviously my point is that this is very similar to the value proposition that we heard many steps along the way since 1973, and indeed sort of echoes some of the things that your Congress person wrote to you a few weeks ago. And that's really where my personal story begins. Actually, in 1973, I didn't know what I wanted to do with my life. And when Nixon signed into law the HMO Act, I was whole hog into that as a great idea. I really was. It was part of how I decided to go to medical school. You know, I thought the basic premise was set up a business model where the healthcare system people can make more money by keeping patients healthier. That sounded much better than the fee-for-service model. So it got me to go to medical school. It got me to go work in managed care for almost all of my career. I was employed by one of the HMOs in Chicago, and then I moved from there to a pharmacy benefit management company here in St. Louis, Express Scripts, where I was a chief medical officer there. And over this career path, experiences kept accumulating that matched the evidence that I kept reading, saying that, you know, this is really not such a healthy strategy. And just one of the stories along the way that I think really typifies the problem that we're facing was I was in charge of a group in Chicago that had, I think, 12 offices, and each office was set up on its own profit and loss as an independent group. We were about 95% capitated, bearing full risk for everything, soup to nuts. And one of these offices in particular was doing just great. You know, it was making money on its own P&L. It had top of the line quality metrics with, you know, every, you know, if there was an orifice, it got a scope stuck in it, you know, everything. They did everything perfectly, and patient satisfaction was through the roof. So I thought it proved my confidence and faith in things. And then this one guy came in and he had hemophilia, and he had a really bad form of hemophilia. And it wound up, you know, I don't know if many of you are docs, not all, but, you know, so hemophilia is this thing where you can't form blood clots normally, and you can literally, you know, bleed to death. And the good news about hemophilia is it's quite treatable. We can give you that factor that makes your blood able to clot. And so he was able to be well treated. Unfortunately, it cost $1 million a year. This is back, you know, a few years ago, $1 million a year to treat him. And that was enough to turn this office that was profitable, that was, you know, finding those colon cancers early, that was finding all that stuff, you know, when it's early and preventable. All of the financial benefits of the quality improvements that they had done were just blown through the roof, you know, by this one patient. And so I was responsible for the P&L, the profit and loss statements for the group. And I got to tell you, I was thinking about things like, geez, if we can just get this one guy to want to stop coming in, you know, wouldn't that be, that would be, that's more important financially than anything else we did. We should not answer the phone if it looks like it's him. We should put him on hold. We should maybe lose his paper chart for a while. We really shouldn't call him back with those test results. There's a whole litany of things that I thought about we should do to make him, what would he complain about? He would say, I'm so mad at you guys, I'm going to go somewhere else. Hooray, you know. So, you know, we didn't do any of those things, but it's been eating at me for all this time that I thought about it. And it's not unique to me in that one office. This is, as I'm sure you all know, which is part of why you're on this call, this is the core model of managed care. Find the healthy people and don't make those sick people want to come see you. And I submit to you that that's not changed. That's not really changed. Getting to REACH has been a relentless march towards privatizing the Medicare system that we, I hope, all know and love. So if you think about it, you know, this movement started in 1973, as I alluded to, and got us here. And then all of these steps along the way were little bits and pieces of trying a different way of privatizing Medicare, or privatizing healthcare, and specifically Medicare. And it took both parties to get here. You know, some of these were started under Democrats and some were started under Republicans. And indeed, as you probably know, President Biden, in my mind, doubled down on the program that President Trump began under an inspiration that was given by President Biden. It's, you know, this is a bipartisan corruption of our government, in my mind. So it took both parties to get here. I'm going to show you those data points against our performance on this chart. So here's a chart. It's a little bit wonky. I think it's my wonkiest chart for the evening. Across the horizontal axis, you see health expenditures per person, and across the vertical axis, you see life expectancy. So, you know, you want to have lower health expenditures and longer life expectancy. So the upper left-hand corner is the good place. The bottom right-hand corner is the bad place. And each of these lines is one country's experience for the last, 50 years, marching along there. And as you can see, in 1970, we were in nearer, you know, we were in the pack, at least. We were in the pack. And then not so much, you know, and now we're just, you know, profoundly gross outliers. And all of these strategies were in part sold with the premise that they were going to be doing the things that the New York Times said, and that they were going to be doing the things that that your congressman says we're going to accomplish. You know, it's really hard to see it. So none of this stuff has worked. It's been a long, continuous slog to get here, and we just have to do better. I want to give you one really practical example of how managed care has failed before we get to REACH. And this is sort of an experiment that we've all been living through for 50 years that we don't often think of as an experiment. But managed care was created in the United States, you know, in 1973. But and Canada didn't do that. Before that, the Canada and the United States were almost the same in terms of the results of our healthcare outcomes. And if you talk about Canadian healthcare, people will say, well, you know, you can't talk about Canada. It's, you know, bigger, you know, it's got, you know, fewer people. It's not as diverse. And I view all that as sort of code words for racism. But before 1971, up until 1971, we were the same in terms of our healthcare system. And there's a lesson here for the flaws of managed care that I want to get to. So before 1971, we were the same. Our expenses were the same as a trend of a percentage of GDP, and our life expectancies were within months of each other. And then in 1973, we went down the road of managed care. And 1971 was when Canada fully implemented their Medicare for All program. And, you know, Canada calls it Medicare, and President Johnson took the word Medicare from them. So we were the same, you know, despite all the things people say about how different we are. Up until 1971-ish, we were the same health outcomes as Canada. And then we had national policy decisions, which I submit REACH continues, national policy decisions. And here's what happens. So healthcare costs as a percentage of GDP has continued this relentless climb upwards to now nearly 19%. And the HMO Act being enacted didn't clearly make any dent on that curve. But then there's Canada. And they put in place their program, and it wasn't just a drop in the axis. They actually changed the slope of their curve. They slowed down their medical inflation. So we were the same, and then we're different. And one piece of the difference might be just looking at how we spend money on hospital administrators, or you can use lots of other examples. But here's an interesting one comparing us to Canada. So look at Duke Medical Center, if I can pick on them for a moment, and look at the University of Toronto hospital system. So Duke, they both have roughly 1,000 beds. Duke has a little fewer. University of Toronto has a few more, but roughly the same ballpark size. Duke has published that they have 1,600 billing clerks for their 957 hospital beds. They could put somebody full-time at the foot of every hospital bed and have a legion of staff left over from billing and insurance functions. Billing and insurance, they have more than one. The average in the country is about one billing person per hospital bed, and Duke is, and so some hospitals have fewer, that's the average. Duke has an extraordinary number, which they actually published, so 1,600. University of Toronto, on the other hand, has 7. Bigger hospital, 7. And as I understand it, 3 of those 7 are to deal with Americans who stumbled across the border and then broke their leg or something. So these are all, almost all, I imagine, really good, smart, hardworking people trying to help our doctors and hospitals and patients navigate this chaos, but they're not producing anything. They're diverting resources from making widgets and cars and teaching and doing social services and all the things we want to do. And REACH doesn't help this problem. REACH adds a whole new layer of complexity to the healthcare system. And just the last sort of point about this little experiment is the most important piece, I think, which is life expectancy. So this data doesn't go all the way back to 1973 because this source doesn't go there for this. But in 1979, Americans were already living 1 year shorter than Canadians. The life expectancies were 1 year longer than ours. And since then, there's been this relentless climb so that Canadians now live 4.5 years longer. American lives compared to Canadian lives are 4.5 years shorter, despite our spending twice as much as they do. So to get to one of the first arguments that we keep hearing about the value of REACH, one of the things we hear a lot is that REACH is a solution or a step forward towards fixing the dreadful problem with fee-for-service. That what we need to do, it's fee-for-service that makes our healthcare system so expensive in the United States. That's a big part of the driver, people say. And so we need to fix that. And REACH is a move towards getting away from that. And as I've just shown you, capitation, managed care hardly does that. And also, before I even show you the things on this slide, I'd like to just point out that fee-for-service, well, actually, that is what's on this slide. Fee-for-service is used all over the world. All of these countries, this is one of the little things I dug out to prepare for this talk with y'all. Each of these countries uses fee-for-service in some form or another. So if the differentiator that's driving up the cost of healthcare in the United States is because of fee-for-service, well, riddle me this, Batman. Why is it that these countries are using it and yet spending half of what we spend? And there are variations on this. They don't all use just straightforward fee-for-service in the way that we are maybe familiar with it here, but there's a range of varieties to it. And each of these tools are things that are bantered about here, except for the national fee schedule that are bantered about here. And yet none of them have felt the need to interpose middlemen in the style that REACH does. None of them have imposed middlemen in the style REACH does. So what are the key lessons from looking around the world about fee-for-service? The first is that you look at one country and you've seen one country's payment model. Every one of these countries that I just showed you has a somewhat different payment model with different elements and different variations on fee-for-service. It's not so much which payment model, I don't think, is what matters. It's that you pick a simple payment model, that you make it universal, keep it simple, and have a way to manage prices. And again, REACH makes it more complex, not simpler. So I think this is a direct quote from Jim Kahn, who I think some of you probably know, that fee-for-service isn't perfect, but the alternatives either don't work or create bigger problems than they solve. So what are we hearing from people on Capitol Hill, as in the letter that you sent us? First, we're hearing that ACOs are good and REACH is better. So REACH is an improvement on the ACO model. And what we're hearing are ACOs have better quality than fee-for-service and have reduced spending compared to fee-for-service. And REACH is now, is being called a type of an ACO. We're hearing REACH emphasizes primary care, prevention, and care coordination. I think those were words from your representative's letter. Remarkably similar to the New York Times commentary on the HMO Act. And we're hearing that we need to shift away from fee-for-service to emphasize quality instead of quantity. And we're hearing that REACH addresses these concerns, that REACH being led by providers, not investors or insurers, that's really an important transformation. And that REACH is so great because it's going to even allow extra benefits to people in Medicare. And I'm here to tell you this is all false. This is all hooey. This is all either completely wrong or just simply so out of context that it's misleading. And I want to unpack that a bit. So more specifically about your congressman, some of them, like him, sound really encouraging. So here's a quote from him in his letter to you. He said, "I do not support privatizing Medicare." Great. And we've heard others say this. Some have suggested that REACH turns traditional Medicare into Medicare Advantage, that it will restrict access to care, or worse, that it would privatize traditional Medicare. And in his letter, he says very clearly, I do not support privatizing Medicare, and am pleased that REACH does not do that. Well, that's pretty nice. You know, I was really real encouraged. And then I happen to remember that just a couple months before that, he was one of the signers on a letter that says, we write to express our strong support for Medicare Advantage. Sorry, you know, how do you square this circle? You know, it's or round this square. I don't know whatever that phrase is. You know, if he says that when he's telling you that he doesn't support privatizing Medicare, you might want to ask him why he's been clearly supporting the largest move towards privatizing Medicare that exists. And we're going to close with some comments about that. So what is privatization? I mean, you know, privatization, you know, what does that word mean? So in the Oxford English Dictionary says privatization is the transfer from public to private ownership and control. That's what privatization is. Transfer from public to private ownership and control. So we've been living through attempts at privatization many times in the last several years. And the one theme, which is part of what's going on here, is changing what's called a defined benefit to a defined contribution. That's kind of wonky language. A defined benefit means guaranteeing, here's the benefits. If you're in Medicare, here's the list of benefits you have, to instead of defined contribution saying, here's a voucher so you can go buy health insurance. We're going to define what we're going to contribute as opposed to a defined benefit. This came up in 1981 when the IRA model was introduced. And ever since then, we've seen a relentless march towards getting rid of pensions, right? People working before 1981 who had a job that had negotiated, I guess, for this, had pensions, and pensions are there are almost no jobs in the country now that offer pensions because everybody's moved to IRAs, which is a way of switching from a public sort of thing into you own your IRA now. So it's, you know, and it's, you know, we've seen risks with that. There were proposals in 2005 to, you know, George W. Bush tried to die on his sword to propose to, I decided not to take a tangent on that comment. They tried to, you know, he really tried to galvanize for privatizing Social Security through personal retirement accounts. His biggest mistake probably was he was just being honest about it. He was just saying, we want to do that. And because he made it so clear and simple, didn't obfuscate it, you know, seniors all over the country said, not so fast, Marty. You know, we don't want that. So that didn't happen, fortunately, because he didn't obfuscate it adequately. And then Paul Ryan in 2012 was really hot on trying to replace all of Medicare with vouchers for premiums. And again, the flaw, the mistake in Paul Ryan's strategy was he told us what he was doing. And that's when people understand these things, they don't like them and they resist them. So privatizing means in Medicare means introducing a profit-centric middleman. And that's exactly what Medicare Advantage is. And sorry, Representative, but that's exactly what it is. And DCE product did the exact same thing. It introduced, as you know, investors as new middlemen. I don't know how you can not call that privatizing it. And there's a lot of talk about REACH fixed one of the problems with DCE because it changed the governance. You know, as you know, DCEs were created with only requiring that 25% of the board of governance to be providers, and REACH changed that, and they're very proud of that. They changed that to require 75% governance by providers. We're going to unpack that a little bit more. But the biggest piece about the triviality of changing the governance board is that it didn't do anything to change the investors. It didn't do anything to change the role for investors. So whether you call it privatization, and regardless of board membership, REACH investors are going to be demanding their return on investment, and they're going to do that from the board. So yes, it's true. REACH changed the definition of criteria, or the criteria for board of directors for these outfits, from DCE's 25% up to REACH's new 75%. And so the myth, which I believe I took from your representative's letter, is this quote: "It's important that the REACH ACO model ensures care is led by providers and not by investors or payers." Wouldn't that be nice. So the reality of this, however, is that a lot of those very providers that are on the new boards of directors, that are on the board of director, are being snatched up. Their medical groups are being acquired by we're seeing the disappearance of these independent medical groups and the emergence of these corporate entities. And the very entities that are investing in REACH are the entities that are buying some of these medical group practices. So are they still, providers? Well, I guess, but they're you dance with the one that brought you. And there's no barrier to the middlemen when they make money, sharing some of that profit back with the members of the board. So the members of the board, there's no guardrail against that. There's no barrier against that. And Medicare or CMMI has the ability to just simply waive. They can simply waive, even though they're touting this wonderful 75% governance rule, which I just give you two arguments against the impact of that. They can just waive that if they meet whatever criteria Medicare decides they want to meet. So they don't have to even go with the 75%. And let me ask you this: if it's true that having provider governance running the organization is so important, why is it 75%? Why isn't that 100%? Why, that's just inconsistent, doesn't make any sense. And the investors, though, are not investing because they care about our health. They're investing because they want an ROI. And so they do that in the ways that I think you're familiar with upcoding and risk scores. And those are mitigated significantly in REACH as compared to DCEs. But when it comes to reconciling at the end of the year about how much their capitation and benchmark and all that, when it comes to that reconciliation, upcoding and risk score optimization is a little more nuanced under REACH, but it's still very much there. They still very much have financial incentives to find ways to reduce delay and redirect care, despite the guardrails. And of course, the biggest game for these organizations is growth. I'm going to say a little more about that in a moment, but they're all about the volume. So we learned, when we at PNHP met with Liz Fowler, the head of CMMI in December, I think it was, we asked her how many members, how many Medicare beneficiaries were in a DCE, and her answer was, I don't know. The head of the Medicare Innovation Center told us she didn't know. She thought it was around 300,000 or maybe more, but she didn't know. Well, we just recently found out that the DCE program had 340,000 people in it in 2021. And we've learned a couple of weeks ago, they published that the DCE program today has about 1.8 million people in it. So it's grown. Remember, when the ACO models were initially being tested, they didn't grow them any bigger than 1.3 million because they said this is too important of a reform. We want to keep it curtailed so that we don't want it to just grow before we have a chance to measure how ineffective it is. But they kept that at a smaller size. We've already blown those metrics out of the water in size, and they're planning to grow it more. So as you know, all of the DCEs today are almost automatically being accepted to become REACHs in 2023, and they're accepting more applications, and there are no published limits to how many more organizations are going to go into this or how big these organizations can get. So CMMI has said that they reserve the right to cap enrollments and to cap new applications. Great, I think that's a good thing, but they have not given us any guidance on what they consider that appropriate point to be. And since they're already at 1.8 million Medicare members, it's pretty hard to believe that they're going to cap it anywhere near, a reasonable, safe, the size you would cap something at for really an experiment. So why are they doing this? I mean, we're already seeing the finances of some of the DCEs really reverse and not be the big profit makers that we thought, and that they thought they were going to be. And yet the investment community is continuing to race into this space. So it doesn't seem to be, it may not be because as short-term profitable as it looked like it was going to be at first under the way DCEs were set up. It may not be quite as much of a profit game, and that hasn't slowed down the growth or the attraction of this to the investors. So what we're speculating is the plan is that they're doing what investment communities usually do. They're planning to grow and sell. And eventually the plan will be, once they've acquired enough growth, to spin off their REACH to probably to the insurance industry. And when you sell a product to the insurance, when you sell an entity like that to the insurance world, the name of the game, it sets the retail price for you, is the number of lives that you've captured. So a plan that has 1 million lives sells for a much higher price than a plan that has 100,000 lives. And that's probably the name of the game. And that's probably the biggest reason why they pushed to have automatic alignment, so that they don't have to actually sell on the TV machines. They can just automatically align 1.8 million. Hardly any of them, as far as we know, opted into this. They were automatically pushed in. And this is the key strategy that they want. The game today for these REACH organizations is to acquire lives, to get them in position to sell. So we're also hearing, of course, that ACOs are, so marvelous and wonderful. And I think some of them probably are. We don't know, because Medicare doesn't publish performance data on a granular enough level to pick out the better from the worst. So we don't know. I happen to suspect that there are some really, really good ACOs, but again, we don't know. We don't know. But the history of them as a block has been dreadful. The history of them as a block, and this is data that was produced by Jim Kahn, whom I think some of you know, and Kip Sullivan, published in the Journal of General Internal Medicine recently, and they found that these groups, at best, the first of these saved Medicare maybe less than 1%. Second one saved again less than 1%. This model actually lost money for most of the time there, and the next gen ACOs actually cost Medicare 0.3%. So these are not models that are. This isn't like a 2-year data spread. This is a 17-year or a 16-year data spread of trying this model, and the results are the same as that first wonky chart that I showed you of all the different attempts at managed care and privatization in our country since 1973 that have not, succeeded. You'll see some published data that says, oh no, these groups are saving money, but those published accounts invariably fail to take in the risk sharing, the profit. They look at just the medical claims and they exclude, the amount of extra money that CMS paid to these organizations. And that's ridiculous. You have to include that. And that's what, we can thank Jim Kahn and Kip Sullivan for doing, was putting together the whole picture and seeing that, no. There probably are some ACOs embedded here that are doing far superior outcomes, but we just don't know which ones they are. And overall, it's a failed model, and it's getting worse. So ACOs, and I didn't quite understand this a month ago, but I do now. Thanks to you, David, for inviting me here. So ACOs can retain 15% of their capitation. The ACO contracts say that they can retain 75% of their savings up to a 20% savings cap. So if they save more than 20%, that doesn't count at all. That all goes to Medicare. But if the first 20% savings they get, they can retain 3/4 of that savings. In other words, ACOs can save or retain 15% of any of their capitation of savings. In other words, from an inexact parallel, ACOs are constrained to an 85% medical loss ratio. It's not really the same thing, but it's the same genre of diversion of expenses. So ACOs can retain 15%. One of the profound changes, people say, well, why did you not react so much to ACOs, and yet you are reacting pretty strongly to DCEs and REACH? What's different? And one of the differences, of course, or the most obvious difference is the big leap in of the investment community. But why did the investment community rush into this? Now that's always been sort of puzzling to me until you look at the arithmetic here. So ACOs can retain 15% of their capitation, not that different, frankly, from insurance companies under the Affordable Care Act, where they were required to have an MLR of a little more than 85%, or 80% for some of them. So not that different. REACHes, on the other hand, for the first 25%, they can retain every penny. They can retain every penny of the first 25% of savings. So that's right off the top. They save every one of those dollars. They retain every one of those dollars, and Medicare gets none of those savings. It goes into the DCE or the REACH's overhead and profit and return back to their investors. So the first 25% they get all of that. And then if they were to reduce costs by more than 25%, they retain large chunks of that, potentially reaching as high as the 40% number that you've heard a few times in the past. It's frankly almost unrealistic to think that any of them are going to hit that 40%. So when we talk about a 40% number, that's theoretically possible, but it's probably impractical. So what's not impractical, though, is knowing that they can save 100% of that first 25. That's a big deal. But if it's impractical to think that they're going to hit that 40%, you really have to wonder, why was that in the request for applications? Why did they build that in? Who were they trying to lure in with those kinds of numbers? Well, obviously, it was the investment community. But not to worry. We've heard from many people not to worry. There's better guardrails. Thank you for telling us about this PNHP, and now we know. That so we put better guardrails into REACH compared to DCE. And I'm here to tell you that better guardrails don't fix a bad road. If you have a really crummy road and you've got a really good road next to it, like single payer Medicare for all would be, the solution isn't just to put up better guardrails. And so then here's what we've heard from CMS. They said CMS is going, this is a direct quote from them, CMS will ask, this is their better guardrail, they will ask for additional information on ownership and leadership and governing boards so they can get better visibility into the ownership interests. Great. Who doesn't like visibility? Well, they also said organizations currently in this model will be permitted to continue participating in REACH. So they're going to get visibility, but they're already pre-approved. So again, this is two sides of, you can't say both of these two things. We're hearing that the DCEs have expanded, have improved the benefits to Medicare patients in this list of things. And then we're hearing REACH is, in addition to that, is improving Medicare by allowing nurse practitioners to certify a variety of things, as you can see on this little list here. So that's touted as an improvement, but I have to worry if that's not going to be part of how if we're going to see nurse practitioners and physicians used in the same ways in terms of disparate communities, and if indeed instead we're going to see NPs being used into lower income areas and physicians just in the higher income areas. So I'm worried about this not helping disparities at all. And if these really are benefit enhancements, if they really are that, why should you have to have a middleman to get these benefit enhancements? Your representative commented on in REACH has enhanced benefits. Well, why do you have to have a middleman to do that? Plus these aren't really the core benefit enhancements we need. These enhancements, and the strategy is increasing new complexity, which is a big part of why we're so expensive. If they really want to do innovations, they should put a cap, they should evaluate a cap on outpatient expenses for traditional Medicare. That's where people are hurting. That's where people are hurting. Put a cap on outpatient expenses, allow negotiating, and add in the missing benefits that, maybe some of the ones from the last page, but also hearing, vision, dental. Those are the things that would really be worth, experimenting with. So I would say it's really important when we're talking to legislators that we manage the narrative. Yes, you need to respond to the things they're bringing up, but we need to be able to manage the narrative. They are responding to things that they're hearing from a really well-funded advocacy organization of proponents in favor of this privatization. They're deluged with those advocates who are well-funded and can afford to be in frequent contact with Congress. And that's what they're parroting back to us. We need to, of course, respond to their content, but we should set the agenda. We should set the agenda and let them try to refute us with our points. And you know what? They can't refute us because our points are pretty strong. For example, that this is being done to seniors without their knowledge or their full knowledge or consent. Refute that. You can't. Well, they're going to get a letter. Well, a letter just looks like mubbledygook and it gets thrown away. And, you know, and so that's a point you can't really refute. And the middlemen aren't in it for our health. They're in it for our money. You know, again, irrefutable. And they can keep huge amounts of what they don't spend. Well, that's the definition of a perverse incentive in designing a healthcare system. It's the wrong incentive. It's dangerous. And why aren't our Congress people, when we talk to them, why aren't they alarmed about that? You know, it should be important. And then, of course, it turns Medicare into a bait and switch program. You know, you get dumped into this program, this new REACH thing, and the only way out is to find a new physician. That makes seniors and people with disabilities really angry, and the fact that it doesn't have congressional oversight. So these are, and that Biden and Becerra could literally stop it this afternoon. They could literally do that. So these are what I think we need to set as the agenda and let them refute that. So here's, REACH. REACH is going after traditional Medicare. 34 million is what I believe the current number of people is. And so it's really important that we try to, fight REACH and DCEs now before they capture, they have 2 million people now out of 34 million. So now is the time to stop this program. But we need to not forget about the fact that Medicare Advantage is, a growing, a present and real danger to us. So while we talk about REACH, and REACH gets, frankly, gets us on the press because it's new and shiny. So, people like there's a new conflict going on. So it got us quite a bit of media play. And that's great. It's been, we need to continue to do that. We need to not lose sight of the fact that the house on fire is Medicare Advantage. So what I would submit to you is we should recognize that Medicare Advantage, that Medicare privatization did not start with REACH, but we need to use this new and shiny thing to make it stop here. How do we get to Medicare for all? Protect Medicare. And if you haven't seen our new nifty, wonderful website that really just focuses on these issues, I recommend that you go to protectmedicare.net. So I have two questions for you. The first, actually one main question. This is the first run of show for this talk. And so, I would actually welcome feedback either now or send me an email the next day or so about what was confusing, what was the most helpful, nobody has seen this slide deck before. And I think there's lots of audiences that want these slides, lots of folks like y'all who want to use these slides. So I would really welcome, critical feedback that's not necessarily, oh, thanks, Ed, that was really nice. I'm really welcoming, embracing feedback.
I think one of the critical things that ACO-REACH people are throwing at us is this is equity. There's an incentive to go into underserved neighborhoods and bring care there, and particularly in people of color neighborhoods. So you didn't really touch on that very much, but I think there's a lot to say that that's a bunch of BS also.
Yeah, I actually chose not to include that just because I thought Claire did a pretty decent job of kind of getting that part of the conversation started. But I was thinking I probably need to do more. So thank you. I'll add more of that in.
Can you talk to that point right now?
Well, yeah, sure. It's pretty interesting. So we were looking at, what is in REACH about equity, and the main thing that's in there is to collect data. That's the main thing, is that they're paying ACOs or the REACH on ACOs if they collect the data. So I looked back to think, well, what's good equity language? And I looked back at HR 1976 and at the Sanders bill to see, well, what do they say about equity? And I hate to tell you, sort of almost embarrassingly, they say the same thing. So our Medicare for All bill in the House and the Senate say little more than let's address equity by collecting data. But the big difference here, the big difference is that one of the single most important things that you can do about addressing equity is give people good health insurance. So our bills don't talk much about, don't go into more detail. And our bills were written in 3 years ago. And so the world has become more cognizant of the importance of addressing this more formally. But REACH does nothing about that core issue. There's nothing about this model. Why, one of the biggest pieces is, underserved communities and communities that have suffered from horrible problems don't have the same health insurance. REACH does nothing to fix any of that. And instead, they're putting this shroud of things around it so that they can say it's equity, it's equity, and it's equity. There's not that what's in there that's going to help with equity. Nothing. It's not going to, it's nothing. And as a matter of fact, there are, all that's in REACH is the request that every one of the REACH groups creates their own equity plan. And I don't think they have to even submit that until, year 2 or year 3. So they have to create their own equity plan. So that means that there are going to be more than 100 different equity experiments going on, none of which are even conceivably going to be scaled up large enough to have anything that you can learn from them. I mean, PNHP had the pleasure of meeting with the Center for Medicare and Medicaid Innovation before they released REACH, and they listened to us. We talked about this issue. They listened to lots of groups, and I thought what they were going to do after this listening tour, because I'm this, pathologically optimistic person, I thought they were going to come up with, here's the 3 equity strategies. We've listened to y'all, and here's the 3 equity strategies that we want to test out across the book of business through REACH. Pick one of these 3, maybe 5, I don't know, pick one of these 3, and then we will scale them up and we'll get some data. No, they didn't do that at all. They didn't propose anything. They said, just collect, tell us the socioeconomic background of your members. Well, no. So they have, no, there's nothing in here about it. If somebody says to you, look at how great REACH is about equity, say, well, specifically, I mean, it's hard to argue against a vacuum. There's nothing there. I don't know. I probably need to flesh that out more. So if any of y'all have other insights on that, I'd welcome that. We're kind of putting that together.
Okay,
So,
Carolyn, yes, go ahead.
I want to thank you very much for mentioning Representative Derek Kilmer. He's my CD6 congressional representative in Washington. He's the one that sent me that letter after we pressed him on this. And we used to meet with him every month, his staffers and sometimes him. And we are asking him to come and meet with us again. And the staff is totally ignoring us. They are not responding to us. They won't talk to us. And so we're starting to press him with our LD group. I post stuff on our friends of, he comes to our meetings. We're going to press him on it. We're going to start standing in front of his office with signs, because he is totally ignoring us and will not speak to us. And that is just not acceptable. So thank you so much, because I'm going to use this and I'm going to send it to everybody, because I'm also on the executive board of our LD and the Democratics, and and that, if you allow me to, I would love to send this to everybody I know who is working on this. And we're doing a couple, we might even have an empty seat town hall next month. We've asked him to come to, and so we're going to try to make his life miserable, because he's just lying to us.
That is exactly the right strategy. So we have met with several members of Congress. We've met with several people within CMMI, and we've met with all sorts of folks about this, and not just PNHP, but some of the best, most informed past administrators and people, they've heard long discussions about this with all sorts of, way more granular information than what I've given you. There's been all sorts of that sort of discussion going on. It doesn't, nothing. The only thing that they care about, the first thing they say is they'll turn to their aide and say, what are the politics of this? What are the politics of this?
Yeah.
What you said, Carolyn, is exactly the thing. We have to make it we're not going to win this fight by arguing against it. We're going to win this fight by making REACH politically untenable to
Yeah.
continue.
And then
And that's the
Patty
way to do it.
Murray is our congressional, is our senator, and she's the chair of the health committee. And we met with her health specialist, and he gave us the same garbage. And so we're pressing her on it as well. And I run an indivisible group, and all the indivisible groups in the state of Washington are on this now. And we're starting to pressure. So
Well, that's the way
Keep going.
forward.
Yeah.
That's the way forward. And I would say, let's be sure to keep Medicare Advantage at the table,
Yeah,
because
Medicare Advantage is all-
that's the house on fire. REACH is the
It
house
is.
on fire next month, or it's starting to burn, but we've got to get rid of this Medicare.
Thank you so much.
Okay, Lisa.
Yes, hi, thanks. Actually, Kilmer is our representative too. I'm over in Port Angeles, and both on, well, I'll start with Susan Rogers. When we listened to her, she made a great point about the hospitals and the services that will come to underserved areas. And of course, we are rural, we have a rural hospital, and Kilmer always brings that up when you discuss anything to do with Medicare for all. Oh, I'm so worried about our hospitals. It's just going to go under if we go single payer. No, I know I'm getting out of that, but the REACH program, we've got a lot of Medicare patients out here. Do we know how that would affect the finances of rural hospitals?
It's a great question, which I'm going to write down, and I don't have the answer for. I don't have any substantive answer to give you.
Okay, but thanks.
But I think it's a really good topic. And I'm actually talking about REACH on Friday to a bunch of a large group of farmers in Missouri about REACH. So that's a critical topic for it. So thank you for bringing it up. I don't have an answer, but I will try to get something.
Thank you.
Thanks.
I think that's really good. And could you, when you get something on that, would you send it our way? If you send it to David, we can spread it around PNHP Washington, if you'll do that.
Yeah, you betcha.
Yeah. Okay, next is Mindy.
I was wondering how imminent this is. You said that Biden could shut it down immediately. Does that mean he can enact it immediately, or how? There's no legislation that is required for this, correct? It's just, the CMS makes a new rule and that's the way it goes. So I'm wondering if how imminent this is as far as like the timeline.
For being shut down or for running?
For REACH to
Yeah.
be enacted or, implemented.
So that's the really interesting thing, or one of the really interesting things about this, is that this does not require an act of Congress. It didn't require an act of Congress to start, and it's not requiring an act of Congress to stop. So under the Affordable Care Act created brand new the Center for Medicare and Medicaid Innovation, which was kind of exciting. It was an idea of, let's create this like DARPA or this SEC, this completely independent group that can do innovations somewhat immune to political pressures. So in that sense, it was encouraging. And so they created it. It's got its own budget. It doesn't have to come to appropriations. It's got its own, it can go to appropriations, but it doesn't have to. It's got a lot of independence. So they, on their own, without going through Congress or any congressional review, oversight, or approval, no new law, just within the range of things created by the Affordable Care Act, they were able to decide, let's do an experiment that became the direct contracting program. And then we all complained about direct contracting so much that they shut it down really prematurely, much sooner than they had planned to. So direct contracting is running today, and was supposed to run for a few more years, and has 1.8 million people in it today. They've already pushed 1.8 million people into it. Direct contracting program ends because of the advocacy work, I would say, ends December 31st, 2022, and then January 1st, 2023, REACH goes live with all the same organizations, entities, all the same patients, plus more organization entities and more patients. So it's in place today, but opening it up and growing it and making it and renaming it did not require an act of Congress. And with that same authority to create it, Medicare has the same exact authority to say, oh, you know, bad idea, let's stop this. So President Biden could instruct Secretary Becerra to instruct Elizabeth Fowler to turn this off, turn this off, you know, and how quickly you could ramp it down, you know, I don't know, you know, turn it down now if you wanted to, you know, give them 6 months, I don't care. But, you know, this could be stopped literally this evening. President Biden could call up Secretary Becerra and tell them to turn this off. And they would. They would not have to go through Congress. They wouldn't have to deal with deadlocks and filibusters. None of that applies to this. This is completely outside of Congress, which is part of the frightening thing. Is that what you were asking me?
Yes, but, and also, is this like, are they gonna like en masse send letters in January 1st, and everyone will suddenly be enrolled in this program who's on traditional, or does it even apply to the Medicare Advantage? I assume not, because those people are being hoarded by the other corporations.
Yeah, that is one of the maddening things, is that it's got nothing to do with Medicare Advantage, that they, you know, they're not, you know, this is only happening to the people in traditional, you know, Part A and B Medicare who chose not to be in Medicare Advantage. And now you're getting this thing that's got some strong parallels to Medicare Advantage. So in theory, when you get aligned, is what they call it, or assigned is what we think of it, or enrolled into one of these things, in theory, the organization, the DCE or the REACH, sends you a letter to tell you that you're now in this, you know. And the letter, the letters that we've seen several, either looked like such dense gobbledygook bureaucratic nonsense that it's hard to understand, at the top of which, in large font, it says, this is a required notice, no action required. So I don't know about you, but when I get one of these, this is a required notice, no action required, and then there's this long technical, you know, fine print thing, I throw it away, you know, and so a lot of those, and then the other ones that we've seen are like the opposite. They're like this, you know, flowery, lovely, you know, your doctor and us, we've decided what ways we can better coordinate your care. Isn't that just lovely? So your care is now being coordinated, and you've got extra, so these other lovely things that, oh, that sounds nice. You know, thanks, I guess. So those are the two kinds of letters we've seen. Now under REACH, we haven't seen it yet, but REACH, it makes one change in that they're going to have a standard letter that the REACH entities have to send. So, you know, is it going to be flowery? Is it going to be techno-garble? We don't know. We haven't seen it yet. But today and under REACH, supposedly you get a letter telling you that you're in one, but there's no way to validate that. You know, so, you know, I'm in Medicare, and I wanted to find out, is my doctor, am I in a REACH? I don't know. You know, I don't think I got a letter that said that, but, you know, I don't know. So I did what I think you should do. I called 1-800-Medicare. They're supposed to have the answers to this. So I'm a Medicare patient, and I called 1-800-Medicare, and the person on the phone was so nice. I'd never called them before. They were so nice, and they'd never heard of a direct contracting entity or REACH or anything of the sort, but they didn't give up. We spent a good 20 minutes with them talking to their supervisors and going back and forth, and they concluded that that's not a database that CMS keeps or has access to. They said, we can't tell you. We have no idea if your doctor is in this. Call your doctor. No. A lot of doctors don't know if they're in one because it's their group that made the decision. And, you know, some of these groups are massive, and, you know, they get the letter from their group administrator and they may not pay attention. So, you know, And then more importantly, if you did find out that you're in one, if you got a letter saying you're in one, you can't get out. The only way to get out of it is by picking a new doctor. Well, gee, thanks. I don't want to pick a new doctor. You know how hard it was to find one I liked. So.
Okay, Andy?
Well, in addition, with the comment about when, my understanding is always 2030 was when they thought this new cancer of direct contracting was going to totally privatize Medicare, and then certain politician members are trying to move that up to 2025. But those deadlines of 30 and 2025 was always thrown out before the new ACO-REACH. But that is, I'm just kind of like piggybacking onto her. I mean, like when she said like our timeline, obviously our timeline should be before the midterms, before Republicans like take control of everything. But what have you heard that number too of the year 2030?
Well, yeah, it's actually on the CMS website. If you go to the Center for Medicare and Medicaid Innovation, they explicitly say, and they've said in all their webinars they give, that their intent is to have 100% of people in traditional Medicare and 100% of people in Medicaid moved over to either REACH or an organization like REACH, 100% of them, or of us, by the year 2030. I've not seen anything in writing saying 2025, but as I said, a moment ago, the program is live today. People are being pushed in it today, nearly 2 million today. And the plan, the overt strategy is to have 100% of people in it by 2030.
Yeah. As far as like the private or the high interest in investment, I just sent an article to the PNHP group here, because Goldman Sachs is like extremely excited about this, and they're projecting great profits off of this. But I think one of the reasons back when David and we were talking about inviting you is because of fighting back against the propaganda, and like the byword of equity, it's popping up in other places too where they use it cynically, because it's like, what, are you against equity? I mean, the other thing is the term high value care. We actually had that happen in our last meeting. Someone off the street, they're like, isn't high value care a good thing? Like it puts us like we're for fee for service, and we sound like the bad guy if we're, oh, what do you have a problem with value-based care? But I've been seeing articles that we really need to attack the concept of value-based care. As much as we need to denigrate ACO-REACH and denigrate, I think direct contracting entity is anodyne by design, because it doesn't sound threatening. That sounds boring. It's just an acronym is going to ruin my healthcare. But in the same way we need to denigrate DCE and ACO-REACH, we need to denigrate the term high value care, because after that incident, I really dug into it because I was like, I should have an answer. And from my understanding of high value care or value-based care, it goes back to a guy from Harvard.
High value-based payments, value-based payments.
Well, I feel like care as well. But either way, it goes back to a guy from Harvard Business School from like 2006. At least. But I just think like in our attack on trying to destroy this movement, we need to really expose that, because I'm meeting people who fall for the bait on that. Like I said, it reared its head at our meeting, which we assumed that was just an accident and not someone like planted, like showing up to like, insert like, they weren't working for the insurance industry. But I think that'd be good. And by the way, as far as feedback, I give you 5 stars. I thought this was amazing. I'll probably be reaching out because I'm gonna have to rewatch this video to digest everything. And I mean, I'm trying to promulgate this. I really think like time is of the essence in trying to destroy this. So yeah, 5 stars, and definitely I think we have your email from the email chain. So
well, this is being recorded, and it'll be on our PNHPWA YouTube site in 48 hours, and I'll send out the links to everybody.
Awesome. Yeah, I'll definitely gonna have to watch this a second time to capture everything. But I think it was I've been advocating that we hit all the independent media channels. I don't know if mainstream media is gonna like even give this the time of day. I mean, one of the biggest crimes with this is that it's happening quietly, and I think that's also by design. So I mean, let does that leave us? We have to go with independent media, which, you know, I'm trying to do what I can on our chapter, but I'm happy to help anyone else with their stuff. I'm trying to get this out because I think we need to get the public outrage going ahead of time. But anyway, but yeah, this has been awesome. Really good session.
Well,
Actually,
thank you. Thank you, Andy. Robbie, you're next.
Ed, we're operating under the assumption that we have to try and get this thing terminated before December. We think that if it gets started in January, it's going to be much, much more difficult to turn it around. So I think Ed is right in the sense that we have to use these midterm elections, but I think we have to start it. And the only other thing that I think that we have to play on is that people deliberately chose traditional Medicare because they did not have a third party. It was between you and your provider. And so that this is a total betrayal of the people that in good faith made a choice not to be in Medicare Advantage, but instead to be in traditional Medicare. And I think that we need to hammer that home as well. But I appreciated your presentation. Thank you.
Yeah, I think there's little that scares politicians more than the idea of an educated and angry and mobilized group of seniors saying, "Hey, I didn't want this. You did this to me. Stop this." And I think you're right. I think that's a really, and I agree with you about the timing. You know, it's, you know,
we're in a campaign right now, and I'm really hoping that every member of PNHP in Washington will join us. The Pizarra is in the and this is just the beginning of the campaign, in the process of sending letters to both the Biden administration and our congressional delegation, making a number of the points that you made, along with the betrayal point that I just made. And we're hoping to have hundreds of people. We now have, I think, Karen, it's over 40 organizations that have signed on to the letters. And we're also asking individuals to sign on to the letter, you know, talking about what kind of work they did when they're retired or what kind of work they're doing now. We'll start off by sending the first letters in around May 1st, but then we hope to increase the number of sign-ons by hundreds. And we hope ultimately to get 1,000 or 2,000 or more people signing on, because we think that's going to get the delegation's attention as well as the Biden administration. So, David, I hope that you will be encouraging the members of PNHP and their families to agree to sign on to these letters that we're looking to send in. The first set of letters will go in May, and then we'll be starting to look at direct action that we think we can take.
Definitely.
great. It's really great. I mean, you guys are inspiring me. You know.
Well, Karen, why don't you say something about the 34th District Democrats meeting the other night? And
oh, yeah, sure. It was great. Part of this campaign is to get organizations and individuals, as Robbie said, to sign on to these letters. And, you know, for legislative districts, they really like resolutions. So we had a resolution drawn up too, and it passed the 34th, and it passed unanimously. I mean, there was no even question once we laid it out as to what was happening, just like you did, Ed, only yours was even better, and we'd love to use yours too. There was no discussion, really. There was no there was nothing. Jeff Johnson, our co-president, did a presentation to the 45th, and you know, it passed, I think, 28-1. Last night, the 11th, passed it unanimously. Robbie, I think you're going to the 37th shortly to do that. So we have a lot of people who are on it. And so it's really important for us to, in our campaign, to get as many individuals also involved. So David, if you could reach out to this group here, let us know if you're willing to sign on and do it as soon as you can. We'd love to have you do that. We're getting close to having, you know, a really good number of people that I think really could make a really difference. And we'd love to hear you, maybe as an aside, Ed, tell us maybe a little bit more about how we can pressure Kilmer, Dale Benny. We'd love to hear that too. You know, anyway.
Karen, just mention the Seattle City Council, Karen.
Great. So I had to swallow here for a minute. Thank you. I just finished my dinner. So we have a resolution going before the Seattle City Council. We have a number of people that have signed up to testify. And Robbie, remind me what date that is, but it's coming up.
That's the 26th.
Yeah, Councilmember Teresa Mosqueda is sponsoring it. And so we'll have an answer pretty soon. So that's pretty significant. So if any of you are in other legislative districts, we have a resolution. We'd love to, if you're interested and able, we'd love to have you present it to yours, or organizations that you belong to that you think would join our campaign. That would be wonderful too. So please let us know. We'd really like to welcome anybody that would like to join this campaign.
I moved to Washington. I'm pretty sick of fighting. Can I move to? I'm pretty sick of fighting for Medicaid. We're still fighting for Medicaid expansion here. I mean, it's driving me crazy.
Okay, David Loud next.
Yes, Ed, wonderful presentation. I just wanted to connect two dots that you put out there. You talked about the investors in REACH planning or may wind up wanting to sell their prisoners to insurance companies. And in work that some of us have done here trying to understand all this, we get the idea that actually the whole design of this may be to create a transmission belt to drive on a wholesale basis people who start out in REACH into Medicare Advantage plans.
Oh yeah.
Yeah.
Right. So you talked about Medicare Advantage, but it's not. Anyway, it has seemed to some of us that is really the design of it, is to boost Medicare Advantage far more than it would be otherwise.
I think you're spot on. My statement that they're gearing just to do the typical M&A sell off to insurers is historically consistent, but it is speculative. And then to go a step further to say specifically to get people into Medicare Advantage, I think you're exactly right, but you know, we don't know that. I think it in part depends on how profitable REACH is for them. You know, they may prefer to keep them here, you know, because they can, you know, the profit margin, you know, the MLR restraints are quite different, or the equivalent of an MLR restraint for REACH is, you know, far more generous than it is for Medicare Advantage. The upcoding gaming is not as powerful for REACH as it is for MA. But, you know, we don't know what it's going to look like 5 years from now, but I think you're right that it's possibly one of them.
And just one other comment, and that is that you did such a good job of talking through the slides and sort of populating each slide, you know, with successive layers of points. I think if we can get your next version of this, now after you've, you know, improved it to your satisfaction, it would be better for us to use it with your presentation rather than just to have the slides, because the slides by themselves aren't nearly as powerful as the slides plus the narrative.
My intent, actually, thank you. That's nice to hear. My intent actually was based on what you all say, like the equity piece that David brought up, based on, you know, the comments that I hear tonight, is to take another whack at making them better, and then maybe even actually re-recording it, sort of, a straight up recording of it as a webinar or just as a recording and making that available. But then I also think the way Claire did the last set was really brilliant, because she put her narrative in the text below the slides. I don't know if you looked at Claire at the slides from PNHP, the first set of REACH slides, but they're public. You can get them. They're easy to get, and they have all of her words just about, beneath each slide, so you can really see how she talks through it.
And your personal story, I may say, was also very compelling.
What was my personal story?
It was how the idea of HMOs got you into medical school
okay.
and your whole career. That story, that was very compelling.
Thanks. It was to me.
Okay, Bet, you're next.
Actually, it's Richard. I just wanted to echo that
Okay.
that slide deck was excellent. It was one of the best slide decks I've seen for a speaker presentation. But the speaker part is very important too, and your delivery was really good. I mean, excellent. We don't want to divorce your delivery from that slide deck. So, but if you ever need to, that slide deck is a great start for just a visual presentation, if that's something that somebody ever wants to do. But the speaking part is very powerful with that slide deck. I thought it was great.
Thanks. That's really nice to hear. Thank you for that.
Okay.
I have dreams in PowerPoint. It's really kind of frightening.
Yeah, I can tell because you're really good at it.
Oh dear, I have to stop laughing long enough. So it looks like Carolyn is next.
Oh, thank you. So there is a question in chat about what is Patty Murray doing, because she is the chair of the Senate Health Committee. And personally, we have meetings with our Patty Murray staffers on a monthly basis, and we've been asking questions continually about this, to the point where we finally got to talk to what they called their Patty Murray's healthcare specialist. And we talked to him for an hour and 45 minutes, and it basically, maybe Holly Brewer can pop in here, because she's my co-conspirator on this. But anyway, he gave us no information at all, and also it was like totally useless. And we asked him, we said, well, how do you justify this? What is the data that shows these DCEs actually work? He said, well, we don't have any data. It's too early to get data. And then we said, why are you proceeding with it if you don't have data? And he said, well, and there was nothing but word salad. So I don't know what Patty Murray is doing. She's a powerful senator, and I feel she's doing nothing. Did anybody else know what she's doing?
Yeah, it was horrible. So Patty Murray is in charge of healthcare for our entire country. She is the chair of the Health, Education, Labor, and Pensions Committee. So she's in charge of our healthcare, and she hasn't sent one letter to say that she has a problem with for-profit entities who have stockholders, shareholders, who need to make more profit every single year. She has not said we don't want those entities in our healthcare. She hasn't said one letter. She hasn't said one thing, and she has no effort. So she has no evidence that this has happened. This is that the DCE model has worked, like Carolyn said. In the meeting, Colin Goldfinch, who was the Help Committee staffer, he's not working for Patty Murray. He works in the Help Committee, but he works for her because now she's the head of the committee. And he said that since Obamacare came in, I think that's 2008, I'm probably wrong, but it's been a very long time, these kinds of direct contract entities have been operating. He said they have no evidence this has worked. They have no evidence it will work. They have no evidence, they have no thoughts as to when they will know when it works. They have no thoughts as to making it accountable. Now, I'm 52, and if people managing my pension accounts told me that within a year, I wouldn't know what they were doing with my money. I'd have severe concerns. So this is Medicare. This is millions of people. And they're saying that they have no evidence it's working and they're moving ahead. And it's been going ahead for years. And essentially, this is unaccountability and dark money is speaking underneath the covers. That's what I see, and that's my speech. So this is Colin Goldfinch, and you can Google him, and he's been in the help committee for years. And he's a spokesperson who, to my mind, covers for the person who's in power at the time.
Okay. Next is Dale Jarvis.
Thank you. It's very clear to me that your strategy of getting Medicare enrollees to speak out and to lend their voice is really important. The counterbalance to this is the fact that all the ACO type organizations around the country have spent enormous amounts of money building the infrastructure to work under this very complex system in order to try and, well, achieve whatever aims they have inside their organizations. And I think it's really important to have a good sense in Washington State, who are the organizations that are operating under these contracting arrangements, so that we can get a sense of who they might be, so that we can kind of know who we're pulling the carpet out from under if we succeed, because that is going to be a kind of a 800-pound gorilla in the political debate. And I'm wondering, do you have any suggestions about the best way to answer that question? Because I think we really need to get organized around that piece of the puzzle as well.
Yeah, I agree. If you dig into the CMS website or the CMMI website, the Center for Medicare and Medicaid Innovation website, they do someplace in there, I've seen the list of all of the DCEs that are operating today and the states in which they operate. So I'll try to find that link and send that to David so that he can share it with you.
I've seen that link, and there's 11 of them operating in Washington State. And, you know, we got the names of them and the LLCs after them and so on. And we're, some of us from PNHP are working with a group of students from Tacoma Community College who have this project they have to do at the end of their senior year in public health. So we're going to have them try to dig up what they can about those 11 entities working in Washington State. So hopefully that'll provide some information.
And I'm sure, you know, healthcare lobby in the state is very powerful. And I'm sure that there's a big crosswalk between the 11 entities and the amount of money that's going in the healthcare lobby. So it's really important to have our eyes wide open about the money part of this, the political money part of this.
I mean, that gets back to the root problem, which is the democracy is broken. You know, if it was ever complete in our country, which it probably really wasn't, but it's really under, you know, assault. So I think we need to align with the groups that are trying to repair democracy and say, hey, here's a kitchen table issue. People care about their health care. We have to get them to realize that this is an issue because of how dysfunctional democracy is.
On the pharma political donation side, Patty's taking over $1 million over the past years. And interestingly, Maria's not taken 1 cent from Big Pharma. But I just thought that is something to think about. Patty,
who is not?
Your mouth.
He meant Maria Cantwell, our other senator.
That she's not taking any money.
Well, not from pharma, but she's got from other healthcare entities.
Oh, definitely.
Yeah.
Well, isn't she like super wealthy or something?
Yeah. Yeah, she's a retired Microsoft executive.
Yeah.
Yeah. Okay, Robbie, you're next in line.
Just real quick, actually, Medicare is under the Finance Committee and not under the Health Committee. I'm not saying we should let off the pressure on Patty, but it's the Finance Committee that oversees Medicare, and Maria Cantwell is on the Finance Committee.
Oh, okay. Dina. Dina.
Yes, this is Dina. I totally enjoyed it. This was very informative for me. I'm kind of new to this subject, so it picked out, gave me a lot to think about. I am wondering though, for regular or community organizations that are trying to get people to get involved with this, things like ACO, DCE, REACH, CMS, CMMI, all of those things don't mean anything to them. And I mean, they're most going to be moved by the idea of they being betrayed and that they may lose their physician and being forced into something where they would have to get a new physician. Most of them, I'm of Medicare age, so, you don't want to have to be changing your physician. But so the only thing I have is like, in terms of like doing a wider range education in the communities and that, I'm trying to figure out how to simplify this, give people the idea of what this means, because it's not just people who are in the fields of healthcare and that, but a lot of people in the communities that really need to know that this is being dumped in their lap without their okay. So I'm not sure what that looks like, but I would be more than willing to try and figure out what that looks like.
I think we have we have worked on that piece. So tonight's discussion was intentionally not that talk. Tonight's discussion was intentionally sort of assuming that you'd already had that part under control. And you're completely right that to show the video of tonight's meeting to a newbie group, really wrong conversation to have. Instead, though, we've already built the introductory tools that you're welcome. We want you to use if they seem like appropriate for the groups you're talking to. And if you go to that protectmedicare.net website, go to protectmedicare.net website, you'll see tools. You'll see written materials, and you'll see actually I think it's about a 30-minute video from PNHP. Our brilliant staff person, Claire Falke, put together a video with a far simpler and intentionally far simpler slide deck that orients you to what this issue is, orients you to how we got here, orients you to sort of, why you should be concerned. So that video exists, and it's, I think, really well done. The slides that she used are available for you if you want to give a talk like that to your own audiences in person. So I would say, you're exactly right. The talk tonight would be really inappropriate for an audience that doesn't already have sort of the basics under control. This is I thought of this sort of like as a level 2 kind of conversation. So,
well, I really appreciate it. I actually work with both kinds because as a commissioner of public hospital district, I talk a lot with groups that are this kind of group. And then I talk a lot also with Washington Community Action Network with community groups. So they're both are needing this kind of education. And I was wondering do you do outreach to senior centers and that, or?
Oh yeah, I mean, we're dancing in every room we can get our hands on. We're going,
Okay,
yes.
well, I will be looking up to see what all you're doing, see where I can help to.
Or frankly, if you have a senior center or someplace where you think a discussion like this would be helpful, let David know, and I'm sure somebody else in the group or me, or we have other speakers. We would be, if Zoom is appropriate for them, we'd be.
Well, actually,
I live and breathe this stuff.
Right, I'm all of South Snohomish County, 250,000 people, so is what I represent, and we represent all the senior centers in this area. So yes, I would be fascinated to learn how I can help to spread this education. But thank you very much. This was very helpful for me.
Great.
Okay, Andy, you're next.
But as far as I remember, it was back in January. I was hearing about how much Wall Street has like embedded themselves, and I mean, inherently they've embedded themselves enough that they would definitely like sue, right? Like they have a, which I suppose that's like across that bridge when we get to it, kind of thing. But is that much of a concern? I suppose, like like if Biden stopped it today or tomorrow, a lot of these investors would be they would definitely be the lawsuits would be going right and left, kind of, right?
Well, and I mean, in truth, I think there are times when public-private partnerships are probably healthy things for the country. And so you don't want to engage a private entity coordinating with the public and just, to totally make them squander whatever investment they've made in that. So in theory, that's, yeah, you wouldn't want to do that. But the other part of that theory is that these are the people that wrote these laws, that created this issue, that put us into this situation. And so, I don't have a whole lot of sympathy for them. Would they have a legal basis for suing? I'm not a lawyer. I can't begin to give a meaningful answer other than to say that it happens all the time. The Medicare innovation projects, they've done, I think 54 of them or something. And, 4 of them sort of worked and the rest got stopped, many of them prematurely, and any public-private partnership that was going on got terminated. And you walk into this knowing that there's no guarantee that this, there's a contract, right? I mean, the DCEs and REACHs are set up with a contract, and contracts have termination language. I haven't really looked for that specifically, so I wouldn't be too, like you said, I wouldn't borrow that trouble. I think the fight would be more political.
Even Medicare was messy. When LBJ first did Medicare, it was not an easy transition initially. So but I'm just anticipating the empire striking back scenario.
Oh, yeah.
It's gonna be messy probably, but whatever. First we have to stop them.
Yep. I'll be glad to have that problem.
Okay. Bet, you're next.
So first, Ed, I wanted to thank you like everyone else is thanking you. It was a brilliant presentation and really clear. But I wanted to just point out a couple of things. People were talking about Patty Murray. Patty Murray's up for re-election. Okay. So if people don't like her position on healthcare or other issues, we can try to run somebody else. I'm just suggesting this. I brought this up. We, this week, lots of us met with an effort being promoted by NNU, National Nurses Union, and that is to go from around the states trying to get our senators to agree in advance to support and be primary co-sponsors of the upcoming Bernie Sanders Medicare for All bill in the Senate, which is, my understanding is that it's pretty much going to be the bill that he presented in 2017 to 2018 and again in 2019. So we met also with Colin Goldfinch. His name is being thrown around here tonight. And yes, he was pretty much as useless as Kevin Chang, who we also met with Cantwell's representative, Kevin Chan. And he told us that Cantwell supports a federal basic health care plan, which is like a public option, sort of pattern after the Washington basic health care plan from years before Apple. So Patty Murray, who's never supported single payer, never was a sponsor of Bernie Sanders' bill twice, recently sent out a survey question. I don't know if the rest of you got it, but I got it, and I was so pissed off I couldn't see straight, where she asked us if she had one survey question, And that was, do you think pharmaceutical costs are too high? So I answered her with a couple of words that weren't like yes or no. And when I tried to send it, it bounced back to me. So she didn't even get it. But basically, this is the same Patty Murray who voted against Bernie's amendment years ago that would have supported pharmaceuticals coming from Canada because it was a lot cheaper than our drugs here, who said no to that. And I think someone mentioned this, and Catwell did also. But I think that someone said this earlier. Basically, the issue is that Patty Murray is getting a lot of money each primary season by both industries, the pharmaceuticals and the insurance industries. And so she is not about to support single payer Medicare for all. So basically, it should be our job to do something about that. She's trying to run again in our state. Do we want her? That's my question to you.
To me?
To everybody. No, not to you, Ed. You're from Missouri.
Yeah.
That would be voter tampering. No, we don't want you to do that.
Lepers don't change their spots. I mean, everything Patty Murray she said way too many damning things. She's not an ally. I mean, maybe we can shame her into doing the right thing, maybe, but she's not by principle, by her personal principles, she's not an ally. She's bought and sold by big pharma and the health insurance industry. Everything she said has been very damning. I wouldn't consider her an ally. Unless she's a weak spine person that we can force her to do the right thing. Simply put.
She might be somebody who listens to Biden, who just recently said he thought healthcare should be a human right, which kind of contradicts where he said that he would veto any healthcare bill that came to his desk.
Medicare for all bill. So David Loud.
Just a quick comment. I tried to put in the chat and Holly Brewer succeeded where I don't think I did in putting into the chat a one-pager that Pizarra has produced on ACO-REACH, and it's going to be improved on, but this, at least I hope, going to Dina's point, isn't so much the jargon, but it tries to cut to the chase. So please look at Holly Brewer's entry in the chat with a downloadable version of that one-pager. That's all.
Have you sent that to PNHP, the national office? I'm looking at it. It's pretty nice looking.
So Mindy. So I think we need to wrap it up here with one or two more questions because we're keeping Ed up way past his bedtime.
I have no idea.
Would you accept a bottle of white or red wine from our great Washington vineyards?
Thank you so much. I don't drink, but thank you so much. And I should send you the bottle of wine because I so appreciate the chance to talk with you all.
I just have a quick question for Robbie. I got your email, Robbie, about signing on to 2 letters, but I cannot figure out how to sign on to 2 letters. So you can email me, or I don't know if we want to take the time.
Yeah, just real quickly, Mindy, you just tell us that you want to be on, and if you and Paul want to be on, then we put you on. I'm sorry.
Okay.
All right, that's all you got to do, and that's, you don't sign on the actual letters. You let us know, and we'll put you on.
So email you back with information.
That's exactly right. Email me back.
Okay, will do. Thanks.
And I was going to say that in a day or two, I'll put out the report of this meeting and the monthly report. And I want to have the links to the Pizarra letters and resolution in there and some other links that we talked about tonight.
You know where to find us, David. You know where to find us.
I do. Make sure you have we have your email. You can put it in the chat now, so you get on our blast list, which is basically only 3 or 4 messages per month, so it's not overwhelming.
Thank you, David.
I would like to just make a closing remark here. Let's see. I'm not quite sure why I'm not coming up, but anyway. I happen to be covered in retirement because by the Federal Employees Health Benefits Program. And I am betting that an awful lot of federal judges, as well as members of Congress and senators, are over 65 and are covered by Medicare with backup of something from the Federal Employees Benefits Program. And they have a federal Blue Cross Blue Shield program that is specifically designed to mesh right in with traditional Medicare. So I don't really expect you to go into that now. The reason I'm bringing it up now as we close is it's another population that is being pushed into ACOs. I got one of those letters that said that I'm now in an ACO. And but you know, I'm not doing anything to need any health care right now, so I haven't had any consequences as a result of that. But it's another powerful group of people who may be approachable in this way.
Yeah, I think you're right. I think it sounds like a really useful audience to pursue.
Yeah. Yeah, and I think most of them don't even think about it. They just assume that because they're covered under the federal employees and they haven't had to pay anything except what gets taken out of their paychecks to pay for the Medigap policy, for the federal Blue Cross Blue Shield. So it's not cheap, but it disappears out of your paycheck before you even know it.
And it covers, it's really got good coverage. Excellent, excellent coverage.
I can attest to that personally, but I won't take everybody's time right now with that. I just wanted to bring that up. So let me finish up by simply saying, thank you to everybody for coming tonight, and thank you to Dr. Weisbart for an excellent presentation. Okay, everybody ready now? And you can go off to bed.
I will.
Yeah, just don't.
Thank you.
Take the time to
Thanks
change
for
into your
this. Thanks
pajamas.
for the invitation.
Okay.